sometimes take me like a day or two to get that posted. So if it's not there right away, I apologize, but it is what it is. All right, it'll be up there though. All right, so talked about laminar versus turbulent. Most blood flow is laminar. We talked about what are some of the reasons for turbulent flow. So most commonly we'll find some natural turbulence in the aorta. So what was mentioned, we have a higher pressure system there. All right, so the higher pressure and the velocity of the blood in the aorta means there's going to be more turbulent flow. Any spot where you've got branching off of the vessels, all right, so if you think about it, the fluid is hitting the branch point, all right, and it's going to cause some turbulence. Stenosis is the term for narrowing a vessel, right? So if we have stenosis of a vessel, that can increase the resistance. That can potentially cause turbulent flow. And again, part of that has to do with that Bernoulli principle I mentioned, where if you have one portion of the vessel narrow, right, but we're trying to get the same flow across, that means we have one small portion where the velocity is going to really increase. Anytime you have an increase in velocity, you have an increase in chance of turbulence. Sclerosis is the process by which the vessels get stiffer, right? So reducing vessel compliance, right? So you probably have heard the term arteriosclerosis before, right? So that is a disease in which the arteries get harder. It's not the same thing as the natural stiffening of the arteries that happens with aging. Okay, so arteriosclerosis is a disease process. There is a natural stiffening of the arteries that just occurs as we get older because our elastin, we lose some of our elastin, basically. Okay, so reduction in compliance of the vessels is normal with aging. The stiffening that was specifically caused by arteriosclerosis, though, that is not normal. Right? It used to be thought that that was a normal part of aging. That just as long as if you got old enough, you were going to get arteriosclerosis. Turns out not the case. So if you look at autopsies of people for whatever reason, if you look at their blood vessels, roughly about half of them have arteriosclerosis, about half of them do not. All right, regardless of what their age kind of is, there's evidence of arteriosclerosis in about half of the population. So it's not a given that you're going to get arteriosclerosis. All right, that is considered a pathological condition. But if you do look old enough in the literature, you'll see it referred to as a natural part of aging. It's been about, now it's been about almost 10 years that we've changed that classification. So I'm starting to feel really old. But anyways, all right, anytime you've got an irregularity in the vessel wall, I mentioned this before, so things like a plaque or a thrombus. Reduced hematocrit, right? Or another way of saying that is the viscosity of the blood. So hematocrit is a term that's used to describe basically how much of the blood is made up of is made up of blood cells versus how much is made up of water. Right, so that's the hematocrit. If we have a reduced hematocrit, what's that going to do to the viscosity? Does the viscosity go up or down, do you think? If we have less red blood cells in the blood. Decreases the viscosity. Why does it decrease the viscosity? It's like thinner blood. It's more watery, right? It's more watery. So think of like water versus molasses, right? So blood with a lot of red blood cells is closer to molasses than it is to water. You get rid of some of those red blood cells, all right, and you're going to have more watery blood. It's going to be it's going to be less viscous. It's going to be more prone to turbulence. So think about taking a spoon through, like rapidly going through water, right? You're going to be able to make a lot of bubbles and a lot of waves. Now try to do the same thing with a bucket of molasses and a spoon, right? Not as easy to make bubbles and waves. What would be an instance where you would see reduced hematocrit, do you think? Blood thinners? Not really, despite the name. So what would cause a reduction in red blood cells? Or what is a condition that we call that? Like sickle cell would do it. That sickle cell is an example of a type of anemia, right? So any type of anemia that causes reduction in red blood cells. There are other things that can do it as well. All right, but usually we refer to anemias when we're talking about getting a reduced hematocrit. Another way would be to just retain more water. All right, so if you're holding on to more water than you should, then there's going to be more water in the plasma, and that'll reduce the hematocrit as well. That makes sense? All right, and then there are a bunch of pathological things that can cause turbulent flow, all right, and particularly things involving the valves of the heart are a biggie. And these can usually be heard. This is what happens this is why the doctor listens to your heart at different places. They're listening for the sounds of the valves, and they're listening for anything unusual, all right? So you can actually hear turbulent flow. They use a French word. The word literally in French means noise. It's called a bruit. So if you hear a bruit, all right, that means there's turbulent flow somewhere where there shouldn't be. If you are feeling the blood vessels, right, you're palpating along an arm or a leg or something, and you feel turbulent flow, that's called a thrill. I don't know why they call it a thrill. That's what they call it. All right, so thrill is feeling, palpating turbulent flow. Bruit is hearing it through the stethoscope. All right, why do we not have turbulent flow in the majority of our system? Because it requires more energy. So laminar flow is more efficient. In turbulent flow, we've got all this energy kind of being expended, going not in a straight line. That's why I said our circulatory system is horribly designed. We've got bends all over the place, right? Very first thing blood does when it comes out of the heart, right? It does what? It bends. All right, regardless if it's a pulmonary artery or the vein, first thing that happens is it branches off and bends. So it's horribly designed. Just saying. Okay. We've talked about this a little bit already. So the extensibility of the arteries is what's allowing for the flow to be essentially continuous through the rest of the system. All right, so the arteries can expand out and recoil back, and that helps to push the blood along. It maintains that mean arterial pressure, right? So even though we have, like, during the systole, we have this increase in pressure, and diastole a much lower pressure, that overall mean pressure is what's driving things forward. And again, I mentioned this, when we age, our arteries begin to lose some of that elasticity. So the arteries become stiffer, and that means we have an increased pressure the heart has to work against. And the pressure the heart works against is a property we call the afterload. Okay, so we get the blood into the heart, we contract, and the blood flows out. The pressure we have to exceed in order for the aortic valve to open and that blood to exit the heart is what's called the afterload. And I'll show you guys in a figure what exactly this means. So one of the things that winds up happening is as we age, as the arteries become stiffer, this ability to stretch and snap back gets a bit reduced. The ability to maintain our steady flow will decline, and we can have regions that will get intermittent instead of continuous flow. What regions do you think are likely to get this intermittent flow as we get older?
Is it extremities?
The extremities, why?
Because it's the furthest place.
It's the furthest away, yes. So what do you know about old people? And
they get numb.
well, not necessarily numb, but was that? Oh, okay. I'm not going for amputations either. I'm getting a little less extreme here. Anybody have, like, either grandparents or maybe your parents are older, and how do they keep the thermostat at their place? Cold, really? Okay, most older people keep it a little bit warmer, all right, and they're almost always complaining about how cold they are. So
they don't get the heat from the blood flow.
Right.
Thermoregulation, so they get cold
All right.
easily.
some of you all have really hardy grandparents. I'm just saying, if they keep your temperature at 64 in the winter, I'm like, okay. I'll tell a story. When I was growing up, I mean, my dad had a supernatural sense. If one of us touched the thermostat a degree higher than the 66 that he wanted it at, he knew about it immediately. So then I went to Florida for like a dozen years, and so I got used to being quite warm. So I'd come up for the holidays, and I would be freezing. I would be wearing 3 layers the entire time. My dad had this insane notion that I needed to open the window in the bedroom to get fresh air in. I got sick every time I went home, and he said that I need to open the window for more air. I'm like, I'm freezing. No, but whatever. Anyways, so all this is going on. I moved to Missouri. I reacclimate to having a winter time, and I'm cheap, so I go ahead and keep my thermostat at a really low level in the winter, high level in the winter without a lot of AC, or in summer, a lot of AC. So I go home for that very first Christmas, and it is 72 in the house, and I'm like, what the heck? My dad has now gotten old enough that he's cold, so he now keeps the thermostat up nice and high. So anyways, so this is again, things you have to look forward to when you get older. All right, your circulation gets a little bit worse, so you tend to feel cold all the time in your hands and your toes. Well, not all the time, but particularly in the winter, you feel a lot colder. All right, something else that happens as we get older, and again, you probably began experiencing this as well, because you are at least of an age where you're going to start seeing that increase, I assume. But our systolic pressure increases. And for most people, it tends to increase fairly gradually, right? But by the time, so I'm going to be 46, I am now up at about the 130 range of systolic pressure. Which, anybody know where hypertension is now considered? Oh no, 120 over 80 is normal. 130 is now considered, depending on who you talk to, either pre-hypertension or hypertension. So they reclassified things so that now basically just over half of the American population is hypertensive. Now, the reason they did that is that from the 130 to 140 range, they don't put you on medication. All right, so if your systolic is at 130, between 130 and 140, what they recommend is what they call lifestyle modification. So getting more exercise, eating better, all right, trying to reduce weight a little bit. All of those things will help, and the idea is they're trying to keep you from getting hypertensive. All right, so as we get older, we're going to get closer and closer. It's going to be easier to get hypertensive, but generally, once you get past a consistent systolic of above 140 and a diastolic above 80, that's when we start to think about, well, maybe we need to start doing some medication to help lower that blood pressure. All right. Now, why do you think that is? Why is high blood pressure a problem? I mean, we tell you it's a problem. We've reclassified everything to make everybody hypertensive, just freak them out. So why? Why is it such a problem? Yeah. Oh yeah, lots of them. All right, so why? Why can it lead to heart issues? The heart is working harder, exactly. So remember what I said, our afterload is the pressure we have to push against, right? So that's reflected by what our systolic and diastolic blood pressure is, right? So the higher our blood pressure, that means that's the harder our heart is working, so that can be causing problems. The other thing is that the higher my overall pressure is, right, that means the higher the pressure in the vessels as we go down. And remember what I said about wall tension, right? It was not just the radius, it was also what? Pressure, right? Pressure times the radius. So at smaller radii, yes, we have a lower wall tension, but if we are at a higher overall pressure, now I'm starting to increase the tension on those vessels. Does that make sense? Those smaller vessels. So I could potentially increase that pressure enough that I could start causing damage. All right, so, and then there are certain organ systems that are a little bit more prone to damage with higher pressures? Anyone want to take some guesses what some of them are? Kidneys is the big one. All right, so that's one of the big things with hypertension. Hypertension can lead to kidney failure. So that's one biggie. Where else? You know? The lungs. Yeah, the lungs are another area. So you can cause damage to the alveoli, which will have an impact on gas exchange. So now pulmonary hypertension is a whole other side of things. Generally, systemic hypertension doesn't lead to pulmonary hypertension. So there's typically not a correlation between those two things. All right. Any questions? Okay. So, oh my God, a whole bunch of figures. What is the point of this? All right. So, simplifying things. So this is looking at kind of our pressure wave, right? So we're looking at diastole, systole, diastole. Don't worry about all the various colors. But we have our aortic arch, the abdominal aorta, the iliac, femoral, carotid, renal. Again, don't really need to worry about which ones they are. What I want you to take a look at is first off the scale, right? So this one's, even though this looks like small, look at the top, we're up much higher, right? Much higher blood flow than the abdominal aorta, right? So here the top is 6, here the top is 30 liters per minute. So what we're looking at here is what's kind of the flow during the different parts of the cycle, right? So it's going to be increased flow during systole, decreased flow during diastole. All right, something kind of cool. Here's my renal artery. See how this one kind of like flattens out? We don't have like this big peak. So the renal artery, and then this is also true of the coronary arteries and the circulation that goes up to the brain, they regulate the pressure to kind of prevent these big swings. So even though we have they kind of reduce that pulsatility effect, so that you get really relatively constant flow through systole to those organs. Sorry, so the renal artery, the coronary arteries supply what? The heart. Now this is a little weird. Coronary arteries, the flow is actually during diastole, not systole. Any idea why?
Can you repeat the question?
Parts pushing unoxygenated blood to the lungs. So
During which part? Systole or diastole?
diastole.
Nope. So remember, systole is the heart is contracting. Diastole, the heart is relaxing. So if I'm contracting the heart, why do you think that might make flow through the coronary arteries difficult? They're getting compressed, right? So during contraction, the coronary arteries are actually kind of getting compressed. During diastole, they relax. So the flow in the coronaries is actually greater during diastole, not systole, just because of the mechanical properties of the heart. All right, does that make sense? But when the blood is flowing, it flows relatively consistent. You don't see this big swing up and swing down, right? And the same thing with the brain. So when blood is flowing, it stays relatively consistent across because we're kind of regulating that pressure. All right, and so this is flow, right? So this is showing flow across all these various arteries. Right here, we're looking at our pressures. So here I've got my systolic, and here I've got my diastolic pressure. All right, now once we get to the level of the arterioles, we don't have systole and diastole. The pulsatility's gone away, right? So the squares are representing mean arterial pressure. So this shows what I was talking about, how the systole, well, I don't really show it. The systole should actually kind of go like this and then down, but whatever. But yeah, so the systole should actually increase a little bit and then come down. But the mean arterial pressure is always going down as we go from arterial side down to the venous side. Right? And that pressure drops very close to zero. So generally between about 3 and 7 millimeters of mercury of pressure is all that's left when we get to the atria of the single heart. All right, something else to notice, right? Systemic versus pulmonary circuit. Notice very big differences in pressures, right? So very small pressure in the pulmonary system, very low pressure system. Okay. Any questions so far? You following decently? All right, so I keep using this term, total peripheral resistance. So we're using Ohm's law and we're going to apply it to the entire vascular system. Oops, sorry. So our pressure differential, right, our delta P, is going to be the difference between the pressure at the aorta and the venous pressure just before the right atrium. Does that make sense?
You said the mean?
No, the pressure
Oh,
differential. Well, we are
differential.
going to use the mean arterial
Oh.
pressure. So our mean pressure, not mean arterial, sorry, because we're also talking about venous side system as well. So we're going to use the mean pressure. There's no systolic, diastolic on the venous side, remember? All right, so we're looking at the mean pressure in the aorta and the mean pressure at the basically the vena cava coming in to the right atrium. Why am I picking those 2 points?
Because they're the largest.
Because they're what?
They're the largest? Or?
They're the largest and the smallest, right? So that's our highest pressure and our lowest pressure on the systemic side, right? So the total peripheral resistance is looking at the systemic pressure, all right? We're going to use our cardiac output to represent the flow. So it gives us that as a formula, right? So resistance equals change in pressure over flow, right? So R equals delta P over Q. So my pressure change, my pressure differential is from the aorta to the vena cava, basically. And then my flow is how much the heart is putting out over any given time period. So this term, P sub V, the venous pressure, central venous pressure, is usually pretty negligible near zero. So remember what I said, that it's like 3 to 7 millimeters of mercury, right? What's the aortic pressure on average? What's the average mean arterial pressure of a healthy adult? Throw out some numbers.
Is it 120?
120 is too high.
Oh. 80?
80 is too low.
Oh, 90.
100 is good. I like 100. Yes, 100 is about mean arterial pressure. All right, so you might see some places might say 95 or 90, but 100 is usually what they typically will give you as your average mean arterial pressure for a healthy adult. Right, which, again, 120 over 80 is healthy, and if you do that, that's actually less than 100, but oh well, 100 is a nice, easy number. Anywho, 100 compared to 3, right? Not a big difference. So most of the time, I will just use the mean arterial pressure and the cardiac output, right? So how do I get this? How do I get the arterial pressure?
We talked about earlier, like catheter.
Okay, so that's one way I could do it. I could float a catheter with a pressure transducer, right? That would give me the authentic, actual aortic pressure. If I wanted to do it less invasively, what could I do?
The cup?
Yeah, just do a regular arm cuff or leg cuff. Your regular old, I'm going to stumble over trying to say this word, sphygmomanometer, the blood pressure cuff. All right, it's easier to say that than the other word. All right, I can just do that. So, yes, if we want full accuracy, catheter would be the way to go, but that's invasive. How can I get cardiac output? Echo, right? We talked about the echo before. We can use that to get volumes, right? So volume over time is my flow. So I can do that. I can do an echo to get the cardiac output. I can do blood pressure to get that aortic pressure. since the venous pressure tends to be relatively negligible, I can leave that out of the term. That way I don't have to float a catheter into my patient to get that pressure. To get this was what's called the central venous pressure, you have to float a catheter that's called the Swan's catheter. Basically, you float it all the way through. You have to go through the heart and then wedge it up against one of the pulmonary arteries in order to get the pressure that you need. So it is not typically done. It is still done somewhat in emergency situations in some cases, particularly if you're dealing with a type of shock, you're trying to determine what type of shock it is, if it's cardiogenic versus septic shock. That's one possibility where you might do it. If there's a like severe hemorrhage going on, you may be doing it to try and see how badly compromised the lungs are. But generally speaking, to get this pressure is a very invasive procedure, and it's not, like I said, not typically done. You're not going to do it with a regular old patient. But the rest of this we could do fairly non-invasively, and generally in a regular doctor's office. A lot of doctor's offices these days have a small, ultrasound device. They can do, some of them can do echoes. So, anyway, but yeah. Let's see, was there anything else? Oh, so we can take the same principle for any given organ, like the kidney or kidneys, the liver, etc., and we can determine the peripheral resistance for each of those segments. Now, when we look at total peripheral resistance across the whole body, this value is always lower than if we're looking at an individual organ system. Right? Because we're not going to get the full cardiac output to, your kidneys, for instance, right? Your kidneys get about like 25% of your cardiac output. So this number is going to be less. Does that make sense?
Yeah.
Okay. And the pressures are also going to be less, but we're not going to worry about that just yet. All right. But and I'll explain another reason why this is a true statement, why the resistance for a component is higher than the resistance of the whole. Actually told you guys at the very first time we talked about cardiovascular, but that was before the test and like over a week ago, so I don't expect y'all to remember it at this point, but we'll get to it. All right, things that can affect our mean arterial pressure and our pulse pressure, right? That difference between your systolic and diastolic. So, just talked about it, total peripheral resistance. So generally, you're going to see an increased total peripheral resistance as we get older, and we're going to see an increase in both our systolic and our diastolic pressures. So if I'm increasing both systolic and diastolic, I'm going to get an increase in my mean arterial pressure. Now I've got this in parentheses, increase in both systolic and diastolic pressures until about age 60. At about 60, and actually by the time y'all get to be 70, it might be 70 by then, because the age has actually been getting longer. But you start to get a divergence. So like I said, systolic and diastolic both go up and your pulse pressure remains the same as you age, right? So if you're 120 over 70, you're going to get to like say 130 over 80, right, as your systolic increases. Once you get to about 60, systolic continues to rise, diastolic kind of plateaus out. So what does that mean to pulse pressure then? Is pulse pressure getting larger as we age, or smaller, or staying the same? Obviously not staying the same since I just said that. So it stays the same until we're about 60, and then if diastolic plateaus out, systolic keeps going up, what happens to pulse pressure? It gets larger, right? Because it's systolic minus diastolic. So if my diastolic isn't changing anymore, but my systolic is still increasing, that means my pulse pressure is going to start to increase. Make sense?
Yeah.
Right, if you remember back before, I was talking about patients with heart failure, though, what was pulse pressure indicating? Was it low? Do you remember? Was it low pulse pressure indicator of death or high pulse pressure? Low. So they actually have a decrease in their pulse pressure. So in other words, the systolic and diastolic get closer to each other. That makes sense? So that's a bad thing. So normal healthy thing, our pulse pressure actually starts to widen as we get a bit older. In heart failure, it decreases, and the more it decreases, the worse the outcome for the patient. Okay, arterial properties, mentioned this before. Arterial compliance. So compliance was, remember, the change in volume to the change in pressure. If we have a decrease in compliance, in other words, how stretchy the vessels are, that's going to be a reason to increase our systolic pressure. So this is kind of the biggie why, as we get older, our systolic is going up. This has less of an impact on diastolic. We can have a decrease or no change in diastolic pressure due to the arterial properties. All right, so if our diastolic pressure is increasing, it's not because of the arterial properties. Does that make sense? So as we're getting older, it's not, diastolic isn't going up just because the arteries are stiffening or the veins are stiffening. It's going up for other reasons. So don't really need to worry about it. But anyway. Unfortunately, we had to cut autonomics from the course for time purposes, but hopefully you all do know what the autonomic nervous system is, right? So what is the autonomic nervous system? It has two branches.
The brain and spinal cord.
Sympathetic and parasympathetic.
Oh.
That's central, but
Oh.
anyway. So yeah, so autonomic is your sympathetic system and your parasympathetic system. So most of what affects our mean arterial pressure is actually autonomic nervous system, right? And most of that is sympathetic, all right, because the vascular smooth muscle is only innervated by the sympathetic nervous system. Right, there's no parasympathetic innervation of the vascular smooth muscle. So where does parasympathetic come into play as far as pressure goes? If it doesn't affect the vascular smooth muscle, where can parasympathetic affect pressure? So it can't be out in the periphery.
So hard.
In the heart.
Right.
Now, how can it affect the heart? Heart rate. Yeah, so heart rate is the big thing. So our remember that driving pressure is based off of the contraction of the heart. So if we increase our heart rate, what do you think that's going to typically do to blood pressure?
Increase blood pressure.
It's going to increase the blood pressure. Then if we decrease heart rate, it's going to do the opposite, right? So the parasympathetic can impact the heart rate, right? Does anybody know how? What nerve is involved? It's one of the cranial ones. It's the vagus. Yeah, so the vagus nerve goes, and we'll talk about this a little bit later, the vagus nerve goes to what's called the sinoatrial node, right, which is the prominent pacemaker of the heart. And there's a consistent tone, essentially a parasympathetic tone. We can alter that tone. So if we decrease the amount of parasympathetic input to the heart, what should happen to heart rate? It increases, right? So the parasympathetic is usually if it's stimulating, it's inhibitory on the heart. So if we decrease the tone, the heart rate goes up. If we increase the tone, the heart rate goes down. Does that make sense? All right, does the sympathetic affect the heart? Yep, it most definitely does. All right, what's an example? What we always use when we talk about sympathetic? What's fight or flight, right? Right. So what does sympathetic do to the heart? Increases the heart rate and something else. What's that?
Blood flow.
Well, I mean, blood flow is going to increase because of the increased rate and one other thing.
Pressure.
I'm hearing a couple other things. What? It will increase blood pressure. Now, just increasing the heart rate can increase blood pressure. We'll talk about that in a little bit. Nope, I'm going for something else. So, what's that? It's going to be cardiac output. We're going to increase cardiac output because we're going to increase something. No, the rate and something else. What about something about contraction? Yeah. Just
Systolic?
the strength of the contraction. All right, so the force of the contraction, sympathetic affects the force of the contraction called contractility. So if you increase sympathetic activity, not only does the heart beat faster, it also beats stronger. Right, so parasympathetic only impacts rate. Sympathetic impacts both rate and strength of contraction. So if you think about it, it kind of makes sense for fight or flight, right? We want a much bigger bang for our buck, so we increase both the strength and the rate of the contraction. Our parasympathetic, we're just, that's your rest and digest, so we're just kind of altering the rate. By altering the rate, that alters our cardiac output, that can alter our pressure as well. So, but sympathetic is going to have much more dramatic impact on pressure than parasympathetic is. All right, and of course the heart is the biggie, right? So that's what's generating the pressure to begin with, right? The driving force. So things that affect the heart, like heart failure, or arrhythmias, these things can impact heart function. That can impact pressure. So high blood pressure can lead to heart failure, but oftentimes once someone is in heart failure, they can actually become hypotensive because the heart isn't pumping as well. It's not pumping as efficiently. So our cardiac output gets reduced and they actually develop hypotension rather than the hypertension.
Just quick question. So when you talk about the pulse pressure, so did you say that increasing pulse pressure is good or is it bad?
So increasing pulse pressure is normal. I'm not going to say it's either good nor bad.
Okay.
All right, it's normal as we age. I said in heart failure, a reduction in pulse pressure was a stronger indicator of mortality. Like the lower the pulse pressure became, the more likely you were to die from cardiovascular disease.
Okay.
So, but remember what I said about the systolic is dropping in the heart failure, so they're becoming hypotensive. So its diastolic is plateaued off, now their systolic is dropping, so the closer it gets, the worse off
the gap, the difference. Okay.
Does that make sense?
Yeah.
Okay. All right, any questions so far? All right, this is a cool, I love when there are simple tools. And so, honestly, the blood pressure cuff is probably one of the best inventions ever because it's very useful for a number of different, non-invasive measurements for cardiovascular health. And ankle brachial index is an example of this. So it's a diagnostic use for peripheral artery disease. So remember what we said, and get older and get that sort of more intermittent flow. Now, if it's seriously bad, you're talking about like having to do amputation of things, then that's what we're talking about here. We have peripheral artery disease, and you have significantly reduced flow to the extremities. Then you can get a scenario like that. But basically, what this is, you do your regular arm measure cuff, and you do one on the ankle. So in a healthy individual, those two values should be relatively close to each other, right? Does that make sense? Remember we talked about that the systolic kind of increases along the tree, but our mean arterial pressure remains pretty constant across all of our muscular arteries, or muscular and elastic arteries. So our ratio is generally pretty close to 1. As that ratio goes down, right, so in other words, as the pressure in the ankle is less than the pressure in the arm, that starts to tell us that there is an issue with those peripheral vessels. That makes sense? So the ankle is obviously further away than the arm is from the heart. So we're using this as an index to look at how is the arteries, how is the arterial system basically doing. And like I said, I found some very cool papers that kind of suggest that this might be sensitive for both central cardiovascular issues, as well as cerebral vascular diseases. Right, so even though we're measuring the ankle and the arm, this value may tell us how well blood is getting to the brain, for example, or what good of shape the aorta is in. Right, so remember I used the term sensitive and specificity, right? So this would be an example of they have some sensitivity, not necessarily some specificity. All right, so again, I don't know how commonly this is used. I've talked with a number of clinicians. Some of them do it, most don't. I think if you're treating a patient that has evidence of peripheral artery disease, this is like a nice, easy measure you can take. And again, with patients, it's always good to do repeat measures to kind of check the prognosis, figure out their prognosis, see disease progression, see if treatments are being effective, that sort of thing. All right. So now, after having gone through all this, can anybody explain to me, why does the blood velocity increase in the venous system? So here we have velocity, right, dropping, and the velocity is going up here. Important. This is one of those times where I'm stressing the word velocity, not flow. Velocity. Go.
Is the volume increasing?
Sort of. What?
I was just thinking like equation-wise.
Right. So how is the volume increasing?
The area is increasing.
Where? All right. In what terms? How is it increasing?
Getting bigger.
Okay. Like what's getting bigger?
The diameter.
All right, the diameter of the individual vessels, right? So we're not talking about the whole system, because really the whole system, capillaries have way more volume and surface area than the venous system does. Does that make sense? So we're literally going from one vessel to the next. So we're following like a red blood cell across the whole system. So as we leave the capillaries and go into the venules, veins, and vena cava, the velocity is picking up. Okay, because as you said, there's more volume, right? Larger radius tube. So what does that mean to the resistance? It's decreasing as we go through the venous system, right? So our resistance is getting much less as the vessels get larger and larger. Now again, we're talking about going from one vessel to the next in line with each other. We're not talking about them as a whole set. All right, so now opposite end of the question. Why is velocity decreasing from the arteries to the capillaries?
Less volume, so more resistance.
More resistance. Yeah, so we have, as the vessels are getting smaller, the resistance is going up. And remember, we're also, pressure is starting to go down. What's some of the reason we lose pressure? Why doesn't pressure just stay up the whole time? Why does it start to drop? The vessels are getting smaller, so right? So if we're looking at volume in the smaller vessels, it should have a higher pressure, right? So why is pressure dropping? All right, take another tack. What is the initial thing that determines the pressure? What's the initial driving force?
Volume.
No. Contraction of the heart, right? So contraction of the heart is what's their initial driving pressure. So why, as we're moving across the arterial system, does the pressure start to drop? We're moving away from the heart, yep. So why is the pressure dropping?
Less contraction. More resistance.
Okay, more resistance is part of it, but why is the pressure dropping? Velocity is decreasing. Okay, so why is the pressure then dropping? Where's it going? Where's that energy going?
Extremities.
Friction, remember? So we're losing energy across those vessel walls, right? So as the blood is flowing, we have resistance to flow, right? Based off the material properties of the vessel. So yes, resistance is going to increase as the diameter decreases, but also part of the reason we see drops in pressure is because we're losing that energy. So friction, basically. Again, not a greatly designed system. All right, so resistance, we talked about that. Resistance is going to be, if we look at individual vessels, right, if we look at an individual vessel, it is increasing as we get to a smaller vessel.
I have a question.
Oh, yep.
Were you saying that that was the reason why the pressure was dropping in the smaller vessels because we're losing the energy to the friction?
Yeah, so as we're moving, as the blood moves across the vessel, we're losing some of that kinetic energy, right? And as vessels get smaller and smaller, more of that blood is exposed to surface area, right, of the vessel, so more and more pressure drop occurs. So they're related to each other. Increased resistance means decrease in pressure, decrease in velocity.
Can you elaborate more on the first one? The first question says increase in the venous system. So were you talking the whole system or is just
So
individual?
we're looking at. Sorry, I should replace that from venous system. Just say it as we move across along the venous side.
Okay.
So here's our velocity. It's
Right.
increasing here, right? We don't
Right.
have a heart located at the level of the capillaries. So something has to be providing that velocity. It's the drop in resistance.
Okay.
So the drop in resistance is what allows us. So very small pressures, right? So our pressure down in our capillaries is, maybe 10 millimeters of mercury. It's not very high. Remember, we're going to get down to about 3. So that pressure differential across the whole venous system is a very small pressure difference, right? So it's not a lot of energy, essentially, to provide energy for flow. So we increase the diameter of the vessels, we decrease our resistance. Even that small pressure difference is enough to get a consistent
So
flow.
the resistance is the key.
Mhm.
Okay.
Yes, resistance is the key. And here's why, right? So if we come down, and don't worry about the specific sizes, right? But just kind of get the idea here, that as we're going down in the microcirculation, when we get to these arterioles, these terminal arterioles that are going to feed into the capillaries, and we have our venules that are taking blood up from the capillaries, we're talking very small diameter or small radius vessels, radius R=5. So very small radius. So individually, a lot of resistance. All right, so blood flow is slowing, or velocity is slowing. Now the resistance is decreasing as the vessels get larger, so the velocity starts to increase again. Just kind of repeating. So capillaries have got high resistance, low flow velocity. All right, so this is showing resistance to, and then, resistance compared to flow, right, current flow, that's the high. So the ratio of the resistance to the flow is what's indicated here. So higher resistance is up here, lower resistance down here. All right. So everything I've been saying up to this point, we've kind of been talking about blood moving from one vessel to the next, to the next, to the next. And we haven't been talking about the systems as a whole. Now we're going to kind of focus in on the system as a whole. So capillaries have got our highest cross-sectional area, right? So here's cross-sectional area. There's your systemic capillaries. here's your pulmonary. Look at that. See how much higher that is? So even though the lungs are not that big a portion of our body, right? We have tons and tons and tons of capillaries associated with the lungs. More surface area devoted to capillaries in the lungs than all the rest of the body. Right, so that kind of tells you how important the capillaries are for gas exchange. Right, they're crucial for gas exchange in the pulmonary system. All right, so here's where things get funky. If we look at an individual capillary, it is going to have a high resistance compared to an individual arteriole. So we were talking about moving from one red blood cell moving from an arteriole into a capillary, and then from the capillary into the venule, and eventually the vein. And we're talking about what happened to that velocity. So the resistance that it's experienced is going along in a series, right? Hopefully that rings a bell from the very first section we talked about. So then we're talking about a series. Now we are talking about a network in parallel, right? So now we're going to talk about all of the capillaries and all the arterioles, and we're going to compare them to each other. So if we compare all of the arterioles to all the capillaries, the arterioles actually have a higher resistance overall. I'm going to show how that is in just, well, next slide. All right, so if you remember, I talked about the idea of the resistance in series versus parallel. When we're in series, pretty easy to understand, it's just a sum of the resistances. All right, so this is showing us, right, a system where we've got these different little segments to it, right? They're showing resistance between segments, right? That's what the R1, R2, R3 are. We have a constant flow, right? Because obviously however much comes in here has to be however much comes out there, all right? There's no other branching coming off of it. So it's going through here and coming out here. The flow is the same, it's a constant. All right, that means there's going to be differences in pressures between all of these various segments. Now, the resistances could be different between all the segments too, but just for simplicity's sake, we're going to imagine that all these resistances are equal. Actually, it wouldn't even matter if they were equal or not, because honestly, the whole resistance is equal to the sum of each of the individual resistances. So I think, oh, I did not put numbers on this one, sorry. So if I were to put, oh, I've got it in a later slide. If I made the resistances equal, I made them all 2, all right, so just a value of 2, what would the total resistance of the series be? 6, right? 2 plus 2 plus 2 plus 2 equals 6. All right. What else do I mention? Let's pretty much that. Okay. Parallel's a little bit different. All right, so here I've got my 3 resistances. Now my pressure differential between these 3 is going to be equal, right? So if I'm say at 10 here and 5 here, then my pressure difference in this segment is 5. My pressure segment in this is 5. My pressure segment in this is 5. So everybody following? Right, so if I have a parallel arrangement, my delta P stays the same. My Q can be changing. Right, I could have different flow in the different segments. And I could have different resistances. That's how I would get different flow. But for simplicity's sake, we're going to pretend that all these are the same resistance. Now, in parallel, we do it a little differently. So instead of the sum, it's the reciprocal of the sum of the reciprocals. Right, so we're going to put my R1 over 1 over R1 plus 1 over R2 plus 1 over R3. That's going to give me my 1 over RT, sorry. So I'm going to show you in a second. Here's the math to make it easier. So again, if I made my resistance 2 all the way across the board, I'm going to have 1/2 plus 1/2 plus 1/2. Right, that's going to give me 3 halves. Now you may be saying to yourself, wait a minute, that doesn't equal RT. So to get RT, I actually have to take and flip that, right? So RT is gonna equal 2/3, which is gonna be 0.6 repeat. So each of these has the same resistance. I have this as my total resistance. Over here, each of this had the same resistance, or I used the same value, a much higher value. We following? Right, so when we talk about things that are in parallel versus things that are in series, this is how we look at the resistance. So when we look at the system as a whole, the resistance in the capillaries is very low. Now, are the arterioles in parallel? If I look at them as a whole system, are arterioles arranged in a parallel network? Yes,
Yeah.
they are. So why then is arterioles, why do they have a higher resistance than the capillaries if I'm looking at them as a whole system, if they've got parallel arrangement?
More friction.
More what?
More friction.
Nope, this time it's not friction. What do I have more of? What's that? I have more capillaries. So the number of things making up this term, my R number is a lot higher, right? So if I have an example, I have 3 here. All right, let's say I have 10 arterioles and I have 20 capillaries, right? 20, imagine doing this with 20 versus with 10, right? My number that I'm going to get, the more I'm adding parallel pathways, the more the resistance decreases. Does that make sense? This is usually the most difficult things to try and figure out about this entire segment, is this concept. Right, so the arterioles are in parallel just like the capillaries, but the fact that there are so many more parallel pathways when looking at the capillary system, that's why the resistance overall is lower. Okay, now if I look at one arteriole and one capillary, which one has the higher resistance? The capillary, right? So that goes back to our in series thing. So if I'm following from one arteriole to one capillary, that's where my resistance is increasing. But if I'm looking at the entire system of capillaries, all the parallel networks, and the entire system of arterioles, all the parallel networks, overall, the total resistance of the system, the capillary resistance, is lower than the arterial because there's so many more parallel pathways. Does that make sense? All right, this also explains what I said before about the total peripheral resistance. If we look at the total peripheral resistance, right, that is going to be lower than if I look at the if I look at the resistance of an individual organ system, right, like the kidney or the liver. So if I look at one part of the whole system, that part is going to have a higher resistance than the whole system because the whole system is many parallel branches. Does that make sense? Right? Yeah.
With the total peripheral resistance, would we assume that in those, if you're bringing it up, we would always assume you're talking about the system?
I'm talking about the whole system, yes, from artery back to the right atrium. So that when I use the term total peripheral resistance, we're talking about everything. Okay? All right. Now, the greatest impact on that total peripheral resistance is going to be the diameter of the arterioles. Right? Because when we look at the whole system, right, we have arteries that are in parallel, we have veins that are in parallel, venules in parallel, arterioles in parallel, capillaries in parallel. Right? When we look at the whole system, the arterioles are the system that have the highest amount of resistance. So alterations to the radius is to the power of what again? Power 4. So changing arterial resistance has a massive effect on total peripheral resistance. So that's the area that we can have the biggest impact on our total peripheral resistance, right? Because we're not changing the diameter of our aorta, okay? We're not changing, we can change the pressure of the heart a bit, right? So we can change our cardiac output, but there's limits, right? We can increase it by so much, but there's only so much we can increase it by. So we can't really change peripheral resistance too much by changing our pressure, right? But the only way we can really have that impact is by changing it at the level of those arterioles. Does that make sense? Another thing is, of course, capillaries don't have vascular smooth muscle, so we can't change their diameter anyways. Is that you following? Yep.
Why does it not apply to like our general? Isn't that really the same reason as compliance?
It would, but so the thing is, remember I said the arterial side is the resistance side and the venous side is the capacitive side. So we use the venous side for essentially like blood storage. We don't typically do a lot of venoconstriction. Now, there are exceptions to that. So for instance, if we have a really big sympathetic effect, we will cause venoconstriction to increase blood flow back to the heart and get more blood out into the arterial side of things. But generally, we don't do a lot of manipulation of the venous side of things. If I were to cause, say, venoconstriction of the venules just past the capillary, what would that do? What would that tend to do? What's that?
You said if you constricted.
If I constricted the venules just past the capillaries, what would that have a tendency to do then? Yep. So what would that do at the level of the capillaries, do you think? If I increase the hydrostatic pressure of the capillaries.
In terms of volume? I mean, not volume.
Sure.
Velocity?
No, don't worry about volume, about velocity. What's happening at the level of the capillary? So I've increased the pressure. So what's happening to the volume? It's increasing. I mean, can the capillaries, well, actually the capillaries can expand a little bit, right? But there's probably going to be a limit to that. So what's going to happen if I'm not allowing flow through and the pressure's going up? What's going to happen? That's one thing. It could potentially burst. But what's something that would probably happen well before we're going to burst? It has to do with something we talked about the very first day.
The shunt?
Oh, not the shunt, although that's a good idea. Had something to do with gaps in the endothelial and how easy things can move through them and not. If I increase the pressure, the hydrostatic pressure in the capillary, what's going to happen? They're going to leak, yeah. Fluid's going to come out. We call that edema. Right? So fluid's going out of the blood vessel into the surrounding tissue. So if we cause venoconstriction by the level of the capillaries, what will happen is we'll get an increase in pressure. We'll have more fluid go out into the interstitium, which generally we don't typically want to do. So that's kind of why that doesn't really happen much. That make sense?
Yes.
Following? All right. All right, but again, yes, we can use venoconstriction though when we need it. Hemorrhage is another example where that happens. Right, so if we're losing a lot of blood, you get more constriction on the venous side as well as the arterial side to try and keep the blood inside rather than outside. All right. This would have been a great break point, but oh well. I still have a few minutes on you guys, so I should be nice. I kept you on, I think twice, so I should let you go. I didn't give you a second break either, did I? All right, tell you what, we'll break. We'll call it a day.
Alright.
Y'all been patient enough.
Can you repeat the total resistance versus the peripheral resistance that you mentioned just past?
Right, so when we're talking about, when we use the term total peripheral resistance, we're talking about
The whole
resistance across
system.
the whole system, everything, arteries, veins, venules, capillaries.
Okay.
When I was talking about the resistance in
specific
one group
organ.
of vessels.
Okay.
That's what I was talking about. So the total arterial, right, small artery,
Yes.
right, arterial resistance compared to the total capillary resistance. That's not the same as total peripheral resistance. Does that make sense?
Okay.
So I was talking about all the arterioles combined and all of the
Capillaries combined.
When I talk about total peripheral resistance, I'm talking about all blood vessels.
Oh, okay.
All of them. Aorta,
Everything.
Aorta, back to vena cava. Everything on the systemic side.
Okay. All right.
What else?
So, when looking at